diabetologist with Emmy Hospital. As usual, he's always here and always goes out loud. Thank you so much, Dr. Lumu. Please take your seat. Our second panelist for tonight is Dr. Professor Kalyesubula, who is a senior nephrologist we all know. You're most welcome. And I think you can see the lineup that we have for tonight. Please come receive your bouquet and take your seat. Thank you so much. Mr. Manish Moore is our General Manager for Micheal. And thank you so much for gracing this session, sir. Now, I don't have the moral capacity or even the authority to invite Mr. Micheal, who is our president in Micheal East Africa, to give the flower bouquet to our next speakers. We shall start with Professor Emmy Okello. He is also part of the panelists today. Thank you so much, Professor, for always being there for us whenever we need you. Whoever is taking photos, please take good ones. Thank you so much. Please take your seat. And of course, our main speaker of today's event, why all of us are here today, Professor Micheal Bohm. Please come forward. He's our main speaker for tonight. Receive your bouquet. Thank you so much, Professor. Thank you so much, Professor Micheal Bohm. And everyone here is ready. Thank you so much, Mr. Sanjeev, sir. I'd like someone to help me carry Professor Micheal's flowers. Thank you so much. Ladies and gentlemen, I'd like to let you know that whereas we are having a physical live event here, we also have the Mauritius delegation online who are watching this event live. So they are following every single proceeding that is taking place now. And without much further ado, please allow me welcome our moderator for tonight, Dr. Lumu William. Dr. Lumu William is a consultant physician and a diabetologist at Emmy Hospital. He is also a senior lecturer at the Uganda Christian University. He is a member of the European Association of the Study of Diabetes, also a member of the Lipid and Atherosclerosis Society of Southern Africa, and also a full member of DFood International representing Uganda. He is the current vice chairman of the Uganda Non-Communicable Disease Alliance and the president of the Uganda Diabetes Association. He is a former member of the board of the International Diabetes Federation Africa region, and his research interest is atherosclerotic cardiovascular disease in type 2 diabetes and how this can be mitigated by well-trained nurses using a chronic care model in the primary care setting. He is also a peer reviewer of International Diabetes Federation and Springer Nation. He has several publications in peer-reviewed journals. Ladies and gentlemen, put your hands together for our moderator for tonight, Dr. Lumu William.
Dear colleagues, Janet, thank you for that kind introduction. When people introduce you like that, the next thing is the expectation. People want to see that matter oozing. But all that said, we shall have the presentations, we shall have our talk. I'm standing in for Professor Kaima. I've just been ambushed. I'm not used to doing these things, but I'll try my best to do what I'm supposed to do. Professor, you're welcome to Uganda. This is the power of Africa. I think the shortest time you've been around, you've really fallen in love with our country. It's a very beautiful country. What we are going to have is that we are going to have, before he speaks, before he opens up before he biases us with the science, we want to understand the diabetes, the different lenses. The SGLT2, how are they viewed by Professor Okello? The Kalyesubula disease, the heart failures, what are we seeing? What's our experience? Then Professor Kalyesubula will talk about kidney. Of course, I'm going to limit you, Robert, I know you very well. When you start talking, you will talk and talk and talk till the cows come home. But I'm the chairperson, so I'm going to limit you. Then finally, I will speak to the scientist about diabetes. So I want to start with people who are going to speak hard material. Then for me, I will come in with simpler material. Emmy.
Hello. Are we supposed to start? Okay. Good evening. Emmy Okello is my name, as you heard. Professor Micheal, you're welcome. We are excited to have you. And you've given the experience and the work you've done last year to inhibitors. And Professor Paul Dabella is at the back. Professor Dabella, please wave to us, is our senior most colleague. And all of you, I see cardiologists here, I see gentlemen, I see people, I see medical officers. Everyone is here, and that's good. Yes, we have a lot of experience. Okay, not about 3 years. Working with SGLT2s, we had Forxiga, Russia, and AstraZeneca. Then the next year, yes, 2024, we had Dapsin arrived in a big way, and basically filled the entire space. On the science side, of course, it was initially approved for diabetes, and I think in late 2023, we started having the indication for heart failure. Initially, it was based on the WHF, which thankfully Professor Bohm was an investigator on. And then later we got to see that you could use it in heart failure with preserved ejection fraction from the liver trial. We had a very good experience with this, although we haven't had a trial, but we're using it as part of goal-directed medical therapy for heart failure. There are a few questions that we continue to ask ourselves. First of all, when we introduce it, do we need to escalate? We know the trials did use 10 milligram of dapagliflozin, and then we have had, especially for dapagliflozin, where doses have now come at 20 or 25. In heart failure, do we need to escalate the dose of dapagliflozin? That's number one. Number two, issues of EGFR, the glomerular filtration rate. Dr. Kalyesubula will struggle with nephrologists. We have failure people when we start getting patient with chronic kidney disease and they happen to have heart failure, either the preserved ejection fraction or with this ejection fraction. Some nephrologists want us to stop the medication. Some nephrologists are happy to have this continuum. So again, we are discussing this. And finally, this evening I'd like to discuss more. If we treated someone, and first of all, this is to you, you could start by answering this. If we treated a patient, on TDMT, supported valsartan, mineralocorticoid receptor antagonists, beta blockers, and SGLT2s, and the ejection fraction went about 50. Say from that they were reduced and now they are normal. Is there a place to drop SGLT2s, or is it lifelong medication? Thank you.
Thank you so much. I think you've heard. But we're joined by Professor Kaima James. She's supposed to chair this meeting. Can you come with me, please? And you leave your this station.
Thank you so much. Please first receive your bouquet. Thank you so much. Dr. Kaima, actually, Dr. Lumu William, okay. Dr. Kaima, okay, I've accepted. He's our moderator for tonight. And thank you so much for joining us. For those that don't know, Dr. Kaima is a senior lecturer at Micheal University of Medicine and a consultant cardiologist at the Uganda Heart Institute. And he's going to be a moderator for tonight. So, sir, sorry for bombarding you, but for now we shall have Dr. Lumu have a talk on diabetes as our diabetologist on the panels. Thank you so much.
I think I'll use this. Of course, it's a drug started in our field, but I was told it. And you see when you have thieves, sometimes they do the work very well. When he talks about this SGLT2, you don't want him to stop. And wait when Robert Stas wants also, we'll talk passionately about it. But this is our drug for diabetes. But of course, it has extra glycemic benefits. But I just wanted to touch on the little aspects of diabetes in Uganda to know the type of patients where we should use this medication for the diabetes. And that one takes me to the profiling of the patients. And that's one thing from Uganda Diabetes Association that we see lacking. When you get the patient, it's very important to profile your patient. As this patient, is this patient having multiple cardiovascular risk factors so that you can choose the right medication? Has this patient suffered from this cardiovascular events that we're talking about? Does this patient have proteinuria? Do they have CKD? Do you go ahead to count the different calculations to make sure that our patients are profiled well? And what about the body health? So when you look at a diabetic patient, it's always very important to look at different aspects: the body health, the cardiovascular disease risk, the kidney health. Now you're talking about even glucose variability, hypoglycemia, instance of hypoglycemia. Just mention that a few. So in diabetes, it's not only just choosing the glyphosate or DAPC, it goes beyond the patient you're seeing. For example, the study which we did, the Uganda diabetes phenotype study, we found out actually that 33% of our patients who are really diagnosed with diabetes insulin, they can't secrete insulin. So chances are high that much as we're talking about initiating these patients SGLT2 right away, these are some of the patients where you might be likely to start the patients on insulin right away with maybe an SGLT2 if they have compelling indications. What about when it comes to the cardiovascular disease risk alone? Again, we have carried out some studies to find out how many of our patients, young patients who have had diabetes for a short period of time, how many of these patients are indeed at a high ASCVD risk? And what we found was appalling. About 65% of our patients are at a high ASCVD risk, and actually fitting very well for SGLT2. And even again, this risk, it is heterogeneous. So not everybody with diabetes has the same risk as previously proclaimed. And then lastly, which I have to talk about here, is that many of our patients presented with complications. There is a systematic review which we've just done where we show that actually 56% of our patients have neuropathy. 19.5% have retinopathy. Nephropathy 17.7%. Peripheral disease 32.3%, and diabetic foot disease 5.5%. So the type of patient you are seeing is already a patient who present to us late with these complications. So as we are looking at the indication of SGLT2, we should also look at these other complications. I think I'm going to end there, but I must announce what is coming from UDA. We are having our conference in July. Please come and attend in big numbers. And also we are, by that time, we are working very hard to have our guidelines in space because they have been approved by the senior management of Ministry of Health. And the last note, please, let's have 1 minute of silence to remember Sister Josephine Ejang, who was a senior diabetes educator working with the Diabetes Association. Let's observe 1 minute of silence. We are so rest. Now, I think before James will take over, now I'm passing on the baton to Robert to talk to us about diabetic kidney disease.
After all you said, shouldn't it be James invited me? You have nothing to say.
Thank you very much, Robert. It's always putting a first one on me, but I agree that I have to invite him mainly because of his stature. I want to allow William to take over this. So he's Professor Kalyesubula, Robert, and he's an Emmy nephrologist in the country, as you know. He's a teacher, he's a mentor, and he's the chief of the Department of Physiology at Micheal University. He's a clinical professor, adjunct clinical professor of medicine at the Yale School of Medicine in the US. He's the ex-president of the Ghana Kidney Foundation, and he's also a consultant nephrologist at Bulago National Hospital and different hospitals in town. And I think we don't have a better person to speak about the use of SGLT inhibitors as pertains kidney disease in this country better than Professor Kalyesubula here. I think a lot of you will agree with me. So we'll listen to your perspectives on the use of SGLT2 inhibitors over the last maybe 7-10 years that you use them in patients with the entire spectrum of kidney disease.
Thank you very much, James. Good evening, everyone. I'm happy we are not talking about disease. Disagree on that with the evidence of this. So it's a great pleasure to be here this evening. And I called Kaina because Kaina is not going to speak. He's supposed to chair this session. So otherwise we're going to introduce Professor. So kidney disease, we have to talk about kidney disease. I think until recently, kidney disease has been always in the background, but it's a very big problem. We know that about 850 million people are living with kidney disease worldwide. That's more than most diseases. And when it comes to countries like Africa, it is a bit higher than the rest of the world at 14%, because for the average of the world is 1 in 10, it is about 10%. So most of the cardiovascular complications, the diabetes, the hypertension, the MI, in the end, they end up causing kidney disease. What is a bit unique about East Africa is that some of the kidney disease is is actually not caused by the big elephants, like diabetes, hypertension, and even HIV. In fact, a study which was done in Uganda and Kenya showed that 66% of the people don't have this. But when people present to us, again, just like they do for the other diseases, they present very late. Okay, thank you. The study which was done by Dr. Bohm for his master's actually also showed that people present to us in stage 5 kidney disease. So when the kidney is falling sick, it is not like the heart. It doesn't make a lot of noise. You don't get chest pain, you don't get symptoms. In fact, we know that 90% of people with kidney disease don't know that they have it. And then 70% have no symptoms. That means that like the other big elephants in the room, you really have to look for kidney disease. I made this background so that you appreciate that every patient that walks to you, if they have diabetes, if they have hypertension, if they have been on any chronic medication, you will not know that they have kidney disease unless you do creatinine or unless you do the analysis to look for protein or beta microalbuminuria. I'm sure the experts are going to talk about that because that's what they use to see whether people are improving. Now, when it comes to kidney disease, those 5 stages we've talked about really don't have much interventions for the first 2 stages. We usually get involved when the kidney disease falls below 60%, or when you present with proteinuria or microalbuminuria, as the trials will be showing us. So our interventions have always begun quite late, and we did not have anything. We actually had SE inhibitors and a bit of the others, sodium bicarbonate. Some of us have used lactulose in the past. So until recently, we did not have much armamentarium to use. So now, since the SGLT2s came, there is very good evidence that even at the higher stages, they can delay progression of kidney disease or even reverse it. So whenever you have someone who has massive proteinuria, even if their GFR is normal, you should start them SGLT2 inhibitors because they will delay their progression. Another important thing that is probably going to be different from the international speaker is that most of the people who have kidney disease, averagely, they get affected at 60 years of age. But in most of our countries, people present to us around 40. The average is 40 years. So that means that if you wait, you are probably going to be very late. So SGLT2s are like a miracle to us. I know they were initiated by the diabetologists, the cardiologists took them on, but now they almost fit every disease. As long as you have proteinuria or a decreased GFR below 60, you can actually start these patients on SGLT2 inhibitors. So we've had good experience with the using dapsine. Now actually some class for dapsine as the SGLT2 inhibitor only. So I think the question which was asked, Emmy, we still struggle. When do we stop? Because the starting is no longer different. The current recommendation is that you should stop you should not start the SGLT2 inhibitors if the GFR is less than 20. There are some studies which show that that goes down. We are talking in the perspective of kidney disease. Okay? Then, if someone has been on them, you probably don't stop until someone either initiates dialysis or they have a GFR of less than 15. But there are also some fewer studies that are showing that if someone's cardiovascular risk is very high, you have to wait and probably continue these medicines. We've had the same argument even for the SE inhibitors, but you have to be very careful one of the problems with Bohm, and I think Professor Tim told me to tell you, that when you start SGLT inhibitors, you have to make sure that your patients are well hydrated. So that is a very, very big issue. In fact, we've had very, very patients going through dehydration, we combine the diuretics, we keep all the other drugs, some of them become hypotensive. So you have to watch that your patients don't get dehydrated. Unless they have heart failure, in which case you actually have to balance, or if they have excessive. So I think for now, that's where I will stop and give it back to the chairperson.
Thank you very much, Professor Kalyesubula, for the snippets on the use of SGLT inhibitors in kidney disease, and also to highlight the importance of hydration in those patients. Maybe, I don't know if this is the time to ask questions, maybe I want you to just make a small comment on what happens when the patients are dehydrated, and why is it important then to hydrate them for the colleagues here. I could mention the importance of that before I invite Professor Bohm to give us his keynote.
Thank you very much, Professor Kaima. So I think we are going to hear from Professor Bohm, telling us that when we start these SGLT inhibitors, actually there is a drop in the GFR. And most people believe that's partly because of the initial dehydration, although it later picks up. And we are going to be hearing about the mechanism of the SGLT inhibitors. Among others is that the SGLT inhibitor is a diuretic in the kidney, such an osmotic diuretic. So it spills the sugar out, you don't absorb it. In fact, for me, I use that, maybe I should have said this. When my patients come, I just look at their urine and I know whether they've been adherent or not. Because if they're on SGLT and I see no glucose in urine, then we begin to have a conversation. I get worried when I see ketones, but we have that conversation and it is always right because that's the mechanism of action. So through that, they can actually cause very bad dehydration in these patients. So, and worsen the kidney function. So you have to be careful for that so that you don't dehydrate your patients. Again, aggravating kidney failure. For the same reason, we don't start SGLTs acutely, and you know that they are also part of the drugs we move on sick days. When a patient is very sick, these are part of the 5 drugs that we move off because they worsen the patient's condition. So we give the patients that drug holiday when they are very sick because they worsen kidney function.
Okay. Thank you very much, Professor Kalyesubula. I think that we are probably preempting Professor Bohm's presentation, so I'd like to invite him, but because he's our chief guest and because of his eminence, I'd like to introduce him in full so that you know the person that Micheal has brought here this evening to tell us about the use of SGLT inhibitors in the university. Yes, you go down eventually. Yeah. So Professor Bohm is a distinguished German cardiologist and the director of the Klinik für Innere Medizin. That's at Saarland University. He will tell you what that means. This hospital is in Hamburg. The hospital that he directs specializes in heart failure, hypertension, vascular biology. A professor of his eminence is highly cited. He's a highly cited researcher with over 350 original papers and a key figure in international cardiology. and the clinical trials that have informed cardiology practice over the years. His key achievements and roles are as medical director of cardiology, angiology, and intensive care medicine at Salem University. His academic focus is in the pathophysiology of heart failure, signal transduction, and vascular biology. He has served as editor-in-chief of clinical research in cardiology, and he has previously served as president of the German Society of Cardiology. As I said, he's the author of over 350 original papers and a recipient of multiple scientific awards. His clinical research interests include heart failure, cardiovascular disease, and he's been principal investigator of several international Math Center studies, including the work of intervention. But today, and the reason why he's here with us is because he's been principal investigator of the DAPA HF trial, which, as you know, was a trial that helped us recognize the importance of SGLT inhibitors in heart failure with reduced ejection fraction. Obviously, now we know we can extend the benefits of the agents to heart failure without ejection fraction, but I think that's the story we're going to hear from Professor Bohm. Professor Bohm, you're most welcome.
So thank you very much, dear colleagues, ladies and gentlemen. I was very pleased and humbled by the warm welcome you provided to me that never happened to me before. I hope I fulfill my task adequately, and you see what I'm going to talk about. I will talk about the role of dosing in prevention and treatment of diabetes, heart failure, and chronic kidney disease. Because what we know now, this is one condition we just put together because there are so many aspects in there interacting, which is also so strong. So these are my disclosures, and I would like to focus on the following topic. The whole story starts with diabetes, and the further steps in the development of this successful drug class is a serendipitous finding. That means there is luck we have not looked for. And all of a sudden, we have a rather global drug which has expanded its indications. I will talk about diabetes and heart failure, so the close association. The PESCO heart failure trials, why they were designed, CKM, cardio kidney metabolic syndrome, which is our new topic and a paradigm change, the interaction of the heart and the kidney, and then how to position SGLT2 inhibitors, including dapagliflozin in the guidelines. So I will come to the story of diabetes. Everybody gave already his perspective on this. I just show this slide. The numbers haven't changed, and this reflects the general problem. We have a sharp increase in incidence and prevalence of diabetes, in particular in Africa and in India and Southeast Asia. So there are sharp increases of these conditions. And this condition is particularly important because it steals life from the affected patients. You can see here that the years, loss of life on the ordinate and the different causes. You can see that there is no much difference between men and women on the right-hand side. And you can also see what we are usually tell our students that this is a vascular condition which predisposes to cardiovascular death is true, but it's only half of the truth. There are a lot of other conditions, such as cancer death, which is shown here, which are affected by diabetes, and you can see that cancer takes away 2 years of life and cardiovascular death, approximately 3 to 4 years of life, when an individual is 40 to 50 years, regardless, because that is the overall view how it is treated. Again, similar in women compared to men. Now, when you then look at cardiovascular disease patients, I brought you this slide, which was generated from the on-target trial, which randomized patients to different types of renin-angiotensin inhibitors, which have had myocardial infarction and a mild stroke. And then you can see here the data separated by people without diabetes or with diabetes. And you can see that myocardial infarction, stroke, and hospitalization for heart failure are strongly enhanced by the presence of diabetes. And when you look at heart failure hospitalizations, in people who did not have heart failure before, you can see that the incidence is roughly doubled. The same then holds true for cardiovascular death. Of course, death as the consequences of these conditions, right? You can see it here. There is a sharp increase. Here are the detailed data. So diabetes is a condition which, of course, can lead to vascular disease, to heart failure, and also it increases the complications of it. Now, of course, I move to the treatment. And the history of SGLT2 inhibitors are depicted here. Very early on, there was a compound called fluorescein, which was isolated from the bark of an apple tree. And here, Freya von Mehring, a German physiologist, found that this compound fluorescein indeed leads to diabetes. And they just looked at glucose in the urine, not in the serum of dogs. So very early on, there was an effect here. And then the concept was further developed by identifying the targets of these drugs. And these are the transporters which transport in the kidney but also in the gut. They transport sodium plus glucose, both of it. And then, of course, there was a further development based here on these findings by Dr. Carol Crane. And then dapagliflozin was isolated and characterized first, and then followed by empagliflozin. So these are the 2 drugs which are mainly in use today. Now, how do they work? What we have here is the glucose transport and the glucose excretion, which is when the glucose, the plasma glucose, exceeds approximately 200, 250. There is the transport maximum of the tubular reabsorption of glucose is saturated, and then the consequence is that glucose is appearing in the urine. And when the glucose levels are high, we call that diabetes, of course, and we can take urine glucose. Now, apparently, this can be influenced, and the idea was just getting rid of glucose via the urine. And this is here a depiction of the nephron. You can see that in the proximal tubules, there is one transporter which is called SGLT2. When the glucose is appearing here, it reabsorbs the glucose and the sodium and brings it back into the circulation. There is a second form of the transporter, which is SGLT2, which has a low expression rate in the distal tubules. And then, of course, this prevents of glucose, but also sodium, to be lost in the urine. Now, what happens now in diabetes? In diabetes, we know maybe due to an osmotic effect, there is a vasodilatation, and there is hyperperfusion, and there is a dilatation of the vas efferents. And this hyperperfusion puts pressure and volume load on these nephrons, and they produce oxidative stress, fibrosis, and the damage of the filter, and you can detect it by finding albumin in the urine. Now, what, of course, is then the consequence in these conditions? vasodilatation and constriction of the efferent arteriole, which brings the blood out of the nephron. This is hypertension and increase of the intraglomerular pressure. So that is what now damages the endothelium and the filter and leads to focal glomerulosclerosis. Now what is usually happening is shown here. Glucose is filtered approximately 180 grams a day, and then it went here through the proximal tubulus, and the SGLT2 mainly, and less of the SGLT2 inhibitors, brings it back into the circulation. And then, of course, you can do the same thing, and then the blood glucose here is lost in the urine only when it's high. Now you can block this transporter, the high potency transporter. The glucose is coming and it is reabsorbed, and then, of course, there is more glucose brought here to the distal tubulus and lost in the urine. So a patient on an SGLT2 inhibitor loses approximately 80 grams of glucose a day, which is about 2 tins of Coca-Cola. Yeah, that's the fact. Therefore, there is a slight calorie loss. However, patients often compensate. So the consequence, what you see in the urine in your lab testing, of course, that these outflow of urine in the relationship between plasma glucose and urine glucose is shifted to the left, and you find, as we discussed in our pre-discussion already, glucose in the urine. So that is a good control to show and to detect if the patient indeed has taken its drug. Now what is now happening is the mechanism why it can protect the kidneys. So the normal tubular glomerular infiltration is depicted here. We talked about that. And then you have now diabetes and an elevated GFR, hyperperfusion. And then there is the juxtaglomerular apparatus. And when the kidney senses more sodium here, it tries to protect itself from losing glucose and sodium, and also to prevent hyperperfusion of the glomerulus, and there is an afferent arterial vasoconstriction. And that leads to the drop in intraglomerular filtration pressure. And this is important. You talked in the pre-discussion about the limit of eGFR. I will come in detail to that point later. But this is the mechanism why there is a kidney protection effect, because the pressure is taken out of the glomerulus, and this is the underlying cause of the protection. You can see it here just for illustration. This is the vas afferens, and this is the vas afferens arteriole, the efferent arteriole at baseline. Now you can see there is SGLT2 provided to this experiment, and you can see a constriction at this compared to it. And then the pressure drops, and of course then there is an improvement. There is an improvement, a drop in glucose, a drop in pressure, and then protection. Now all these oral anti-diabetic drugs have to be undergo safety control. That was the demand of the FDA. After one drug called risperidone has shown an increase in hospitalization rate. So they demanded safety studies of the size of outcome studies, indeed to provide safety, only safety of the drugs. Now, and then there was one of these safety studies that was called the Emperor outcome trial. Was studying patients at a high cardiovascular risk, so additional risk factors in diabetes. And to the surprise of many people, but including also the investigators, there was a significant reduction of the primary outcome, which was cardiovascular death, myocardial infarction, and stroke. And this primary endpoint was mainly carried by a severe reduction of cardiovascular death. Why? The MI and the stroke endpoints were not significantly reduced. However, there was all-cause death reduction, surprising, with an SGLT2 inhibitor in an oral antidiabetic drug at that point of time. But there was also a striking finding that the hospitalization for heart failure was reduced by 35%. So that, of course, was a surprise here in these findings. So this was a finding, and now we had these oral antidiabetic drugs with an increase in hospitalization rate for rosiglitazone, and there is also, this drug is still on the market, that is pioglitazone. But now it comes that there was one in the first oral anti-diabetic drug class providing a reduction in heart failure hospitalization. And these were patients who were not in heart failure. Only 10% of the patients had the history of heart failure. This was completely uncharacterized. It was just ticking one box by the investigator. So it was a black box who really these patients were. Now this was then of course confirmed. This was the first study you've just seen. And then these people at the CANVAS study, dapagliflozin, reproduced these findings and dapagliflozin in the DiClercq trials. These studies were enriched by established cardiovascular disease, as you can see here, or just cardiovascular risk factors, as shown here. So different population, but altogether they were really showing this effect in a rather broad population of patients with diabetes and cardiovascular risk. Now I come more detailed into the cardiovascular outcome trial with dapagliflozin, and that was a DiClercq trial. And what you can see here is a summary of all the data which were in these investigations. And here is the line of neutrality. This is the hazard ratio of 1. To the left, dapagliflozin is better, and to the right, placebo. So what you can see that none of the endpoints, including cardiovascular death and heart failure hospitalization, all the kidney endpoints, death endpoints, MI and stroke, they go into the right direction. However, not all were significant. So in that time frame, you can show the treatment effect size. And what was significant was, of course, cardiovascular death and hospitalization for heart failure in a diabetes trial, not in a heart failure trial. And this is the classical endpoint for heart failure trials. You can see it also for kidney endpoints, MACE for the kidney. You can see for the kidney endpoints, 40% decrease in eGFR, the end-stage renal disease, or death for cardiovascular disease, the strongest impact, and you can see for heart failure hospitalization. So these were the diabetes trials. When you just look now in all the studies, you can see that with a great homogeneity, treatments, DiClercq, CANVAS, and BREATH outcome, there is a 35% reduction of end-stage kidney disease and a substantial loss, 40% decline of eGFR. One has to do these meta-analyses because the single endpoints were rather rare in the individual trials, so putting them all together and making a meta-analysis increases the statistical power. That was the reason why this was done. So there was two things in diabetes, a reduction of heart failure and protection of the kidney with SGLT2 inhibitors, across different drugs, across different risk profiles concerning cardiovascular disease. Now, this was one of the first guidelines, the European ESC guidelines in diabetes, which have taken that up. And SGLT1 inhibitors is a clear and crystal clear class 1 indication. The ESC definition is if you give a class 1 recommendation, that means in Queen's English, it is a must, it has to be done. Then 2 randomized controlled trials, at least, or 1 meta-analysis. And I've shown you just, we have CANVAS, we have DiClercq, we have BREATH outcome, and we have several meta-analyses. It's a crystal clear class 1 recommendation. And GLP-1 receptor agonist starting with the LEADER trial. Now the other trials are coming, have shown the same effect. And so therefore, independent of HbA1c, so just in diabetic patients, right? Even though the sugar is not controlled, don't go off these drugs because they affect, of course, glucose, but they affect principally cardiovascular endpoints independently of diabetes. I will show this to you. They should be given definitely. And then if the blood glucose is not controlled, you can go for metformin and pioglitazone, but not in heart failure patients. It's contraindicated, should not be done, only in rare cases. And then you can, of course, take care for glucose by these other interventions. So that is the bottom line of the ESC guidelines. Now we have seen data in diabetes. Now what is the association? Why is it so close together, diabetes and heart failure? I brought you this slide which looks a little bit busy on the first view. On the left-hand side you can see mortality. On the left-hand side you can see mortality here. And these are patients who have no risk factors. If I set the standard, And then diabetes have no risk factors. There is no significant, although it's slight numerical increase of deaths, when all risk factors are controlled. When there is no control of 5 risk factors, you can see a 5-fold increase of risk on cardiovascular risk. On the right-hand side, you can see myocardial infarction. What you can see that, of course, when 5 risk factors are uncontrolled, we have a 7.7-fold increase of risk. But when you control all cardiovascular risk factors, blood pressure, glucose, and also cholesterol and others, no smoking, you neutralize the risk for myocardial infarction. That is possible. That is, of course, the clear evidence for risk factor control. But when you then look at stroke, again, no risk factors or control, no significant residual risk for stroke. But for heart failure, it's different. For heart failure, you cannot eliminate the risk of heart failure, hospitalization, and diabetes by providing vascular control. Of all of them, there is a residual risk of 2.4 that is remaining. And of course, when 5 risk factors are uncontrolled, it goes up to 11. So heart failure is slightly different. You cannot, by vascular risk factor control, completely eliminate the heart failure risk. Now, what happens here? So this is the population-based study, a rather classical one. It's the population-based right-driven study from Iceland. 3 groups, people in the population, normal, abnormal glucose regulation, and diabetes, separated by men and women. And what you can see here clearly that there is about 80% increase when there is abnormal glucose regulation, and full-blown diabetes more than doubles the risk for new onset of heart failure, or heart failure is more prominent. It's the prevalence here. You can see it is similar in men and women, slightly earlier in men, and it is strictly age-related, in particular in women. So if there is a population with glucose control, the diabetes prevalence is increased. And what about the vice versa situation? People who have no diabetes at baseline, here you can see a follow-up over 8 years, but they are in heart failure. You can see that people who have a low-grade heart failure, class New York Heart Association 1, has this risk, which is considerable over 8 years. But the more severe heart failure is, the more likely it is to have an increased incident of diabetes. So heart failure predisposes to diabetes, and diabetes predisposes to heart failure. So there is a close interaction, a vicious cycle in these metabolic heart interaction to get heart failure or to get diabetes when heart failure comes first. Now, what are the mechanisms? We have neuroendocrine activation promoting insulin resistance, also shifting away the blood flow away from insulin-sensitive organs, by catecholamines, for instance. We have a lot of oxidative stress damaging the heart on the left-hand side via microvascular disease, including, of course, the diabetes when it is there, and also providing insulin resistance. So these are the proposed mechanisms. Now, what was then the heart failure as to the heart failure trials? Now, you can see here again EMBRACE outcome. You can see here typical heart failure endpoints, hospitalization or cardiovascular death. That is what usually used in the big trials. Hospitalization only, cardiovascular death and all-cause death. And then they separated the population into heart failure at baseline, yes or no. Yeah, they were only 10% with history of heart failure. And what you can see that those patients who had not heart failure, not known heart failure, had the same risk reduction of heart failure hospitalization as patients with heart failure. This indicates that in this population of insulin or of diabetes patients with diabetes, you can prevent heart failure because they have not had heart failure before. And that, of course, cries for a heart failure study. And we have 2 of them. The first one was dapagliflozin with the DAPA-HF trial. Shortly thereafter, there was a publication of the EMPEROR-reduced trial with empagliflozin. So what you can see that there is a 26% reduction with dapagliflozin in DAPA-HF, and there was a 25% reduction in EMPEROR-reduced. So there is high agreement at a high level of reassurance with 2 drugs from one class this drug works in heart failure. The interesting thing is, or not the interesting thing, but the fact is that in these trials, there were not only diabetes. These were patients without diabetes included. Approximately half of them had diabetes, the other half didn't. So this is what we have here. Another thing which is obvious, that these Kaplan-Meier curves separate very, very early. I come to that point later, and then further separate as time goes by. Now, you might ask the question, okay, maybe these patients were poorly treated. And then, of course, there is more room for improvement when there have inadequate treatments. These are the data from DAPA-HF. You can see yes or no, ACE inhibitor and ARS, also achieving the target dose. That target dose above 50% with beta blockers, all kinds of combinations. To make a long story short, this effect is completely independent on the baseline treatment, whether it is excellent or just good. Yeah? And this makes the point that the effect of dapagliflozin is independent, and this is the first hint that it justifies the role at the fourth class of drug in the guideline-directed medication for heart failure patients. You can see the p-values on the right-hand side, they were completely neutral. So that is an independent effect from other baseline treatments. Now, what about diabetes? These trials randomized patients with diabetes, no diabetes, yes diabetes. You can see this is almost the same here, other numbers at risk. You can see the full lines on placebo in black and here yellow on dapagliflozin, without diabetes below. And what you can see is that the presence of diabetes, regardless of whether you treat them with dapagliflozin or placebo, approximately by 40% increases risk. This exactly fits to the data I've shown before, that diabetes enhances the risk of the complication, hospitalization, and death in heart failure patients. But what you can see that the treatment effect is the same. On the left-hand side, you can see the composite endpoint. On the right-hand side, you can see worsening of heart failure, which was either hospitalization for heart failure or urgent presentation in the emergency room, requiring intravenous fluid diuretics. So the same thing, increased risk by diabetes, treatment effect approximately the same. Now you might argue, okay, maybe if the threshold of diabetes plays a role. So the investigators, we looked here in both trials of the treatment effect across baseline hemoglobin A1C levels. Here is the line of neutrality, and here is the treatment effect. And you can see that over the whole course, the treatment effect is below the hazard of 1. And you can see that statistically there is no interaction, absolutely no interaction with the treatment effect and HbA1c. And this indicates that the SGLT2 inhibitors made the step away just being a glucose-lowering drug towards being established in a heart failure drug in patients with diabetes and without diabetes. Now what about diabetes? Back to diabetes. In this analysis, we looked at the new onset of diabetes on dapagliflozin. So from the DAPA-HF trial in heart failure, all patients were eliminated who had diabetes before. This is just a population without diabetes at baseline. And then you can see that indeed there is, after between 3 and 6 months, a difference. So the new onset of diabetes, and I've shown you data that heart failure promotes diabetes, is significantly attenuated. 63% reduction of diabetes, new onset of diabetes on dapagliflozin in heart failure. Maybe this could be a little bit a contributor to the outcome effect as well. Now, what are the guideline recommendations? The CLEAR study, 2 big trials, also a meta-analysis, which I skipped here, have shown an effect on heart clinical endpoints, cardiovascular death and heart failure hospitalization for 2 drugs, SGLT2 inhibitors, dapagliflozin and empagliflozin. They act independently of the others, and this provided the reason to put it as an independent class 1A recommendation as the 4th component of the standard treatment of heart failure with reduced ejection fraction. Now I come to the next point. So first of all, one view on our classification we have now in heart failure. It's heart failure with reduced ejection fraction and preserved ejection fraction. The 2016 guidelines put in between the third group, which was then called mildly reduced ejection fraction, because nobody exactly knows what to do with it. Now we know these are sick people, so it's called now mildly reduced ejection fraction. Honestly, this is just an arbitrary classification. It is not based on any physiology. It is just done by a group of guideline makers, not more. I do not want to downplay this. They are really good people, but they did it. And no, the reason to do that is they wanted to separate the two groups clearly, because of course when you do an echo, there is a big overlap between all the groups, to make definite studies in reduced and preserved ejection fraction. Now in the last guideline committee in 2023, we voted whether we could take it away. You will see the reasons in a minute. And in the next guideline, there is a good chance, I don't know how they decide, to put these two groups into one box and name it reduced ejection fraction, and this one normal ejection fraction. We will see the guideline will be presented in Munich at the European Congress of Cardiology. Now this is what we have. Now what happens now? We talked about reduced ejection fraction. That is DAPA HF, below 40 ejection fraction, but what about the people above it? No. You think you have to help me? It does not move further. They also work in heart failure with mildly reduced ejection fraction. That is one of the reasons. That will be a tremendous change. Therefore, it was not done in the update, it will be done in the re-guideline discussion. Now, what about heart failure with preserved ejection fraction? You know all these data on these gravestone. There are all the trials which failed. These are a couple of $100 million. Yeah? So ACE inhibitors, this is the PEP-CHF study with peripheral neutral. I preserved was neutral, is the result. Beta blockers have not really been tested. Meta-analysis show not working. Ivabradine, Edify trial, not working. Aragon sharply missed the primary endpoint by 7 events, and spironolactone was neutral starting at 45, and then was neutral above 55, and had also some problems with some of the populations. So it takes a lot of really effort to do a trial in this and to invest. And this here is the reason why there was an X22 trial in FF. You can see in this analysis the event rates in different heart failure trials. The names are down here. The yellow ones are heart failure with reduced ejection fraction trials. The red ones, heart failure with preserved ejection fraction. And then you can see, first of all, that the REF trials have a higher endpoint number. These are all just the placebo groups, yeah? Not to interfere with the treatment effects. And then you can see Stefan Anker, who was here the father of it, took the EMBRACE outcome trial on placebo in these patients who ticked the box of heart failure. And what you can see, that the event rate in these patients is more associated to have F trials than to have REF trials. And he argued that these patients who have had a treatment effect, that these patients might have had FF. And that was the argument to do a trial in heart failure with preserved ejection. And here they are. You can see Emperor preserved and deliver, where the two trials done. And again, you can see that there is high agreement between the trials, approximately 20% risk reduction, number needed to treat 20 to 24. Again, curves separate quite early. So these are the data now that we have covered the full ejection fraction spectrum, because traditionally these FF trials include also FMF. Yeah? There was no difference between below 50 and above 50. So therefore, over the whole spectrum of ejection fraction, dapagliflozin and others work. And here you can see the heart failure trials, deliver and preserve. They show exactly the same results. No heterogeneity and not in the individual components. So by increasing the power of the trials, we even find a reduction of deaths numerically in these trials. So therefore, we have now indeed 40 plus ejection fraction that works. Similar data were now analyzed concerning diabetes. This is here deliver with dapagliflozin, non-glycemia, pre-diabetes, and type 2 diabetes, full-blown diabetes. The treatment effect is similar among all groups. You can see the risk reduction here, the interaction p-value, no difference between the metabolic status of these patients. Now, what happens to the well-being? That is interesting. These trials not only capture the outcomes, but also the quality of life. This is usually measured with Kansas City Cardiovascular questionnaire, different scores. TTS means TSS, total symptom score, which is shown here. And what you can see before a patient goes to hospital, and this is another interesting clinical finding, about 3 to 6 months before, there is a sharp drop in quality of life. Yeah? And this in DAPA-HF and in deliver, it's more visible here in reduced ejection fraction. But what you can see across the spectrum of ejection fraction, there is an increase in all of these scores, so in broad domain of well-being, independent again of ejection fraction, there is an improvement of quality of life. Now, is it dependent on the severity of heart failure? It's not. You can see if the heart failure has a higher class according to New York Heart Association, so people feel worse, there is a better effect of SGLT2. This is not high rocket science. When people feel particularly bad, you can make them easily better. Yeah, it's not. It's quite clear, but across the gradient of symptomatology, this effect on well-being is maintained. Now, when should we try? And you know the guidelines. Start as early as possible, and including SGLT2 inhibitors, and including heart failure with preserved ejection fraction, because these data were mainly available in reduced ejection fraction. So what you can see here is the time after randomization and the treatment effect. This is the upper boundary, this is neutral effect. This is a line of neutrality, risk 1, shown here, and the upper part darker and the lower part emperor. And you can see that the upper boundary of the treatment effect crosses the line of neutrality at 28 days, or even in HFpEF at day 13, similar day 12, day 34, and here day 18. So that means when you have made the diagnosis of heart failure and then you start, for any reasons, you don't introduce your treatments, when you expand them below 13 days, you bring the patient at risk for a cardiovascular event. Yeah? So this clearly indicates that treatment should be started with all the drugs, and there are also for REF data for sacubitril/valsartan, for mineralocorticoid antagonists, and for beta blocker. It's all the same, and this was one of the arguments to start as early as possible, including the false pillar. And here you can see how big the effect is. This is readmission for heart failure or mortality. This is starting SGLT2 inhibitors within 3 days. And this is postponing the treatment. So try to be as fast as possible. There is no such thing as stable heart failure, that suddenly they go all of a sudden into the hospital and all these kinds of things. Now, what about myocardial damage? So it was looked here in DAPA-HF on the marker of troponin, which means cell death. Continuous cell death. And you can see quartiles, low values, high values. The outcome rate is, of course, 4-fold increased in patients with a low compared to the high troponin levels. That is a marker which clearly indicates the highest risk. And then you can see that the treatment effect is not interacting with the height of troponin. So the severity of heart failure does not play a role. And then you can see you combine it with anti-proBNP, which is of course elevating the outcome rate. But when you do it together with TNT, troponin, you can see that there is from both low to both high a 10-fold increase of risk. And these patients particularly require all 4 treatment schedules. Now, what else can be done when you have a patient with a diagnosis of heart failure and you cannot get an echo, and you do not know whether there is FRF or FF, you can immediately start. And the reason is that across the ejection fraction, here you can see, in non-severe and severe heart failure, there is always a treatment effect of SGLT2. This is dapagliflozin. This is putting together DAPA-HF and deliver, and you can see this is the only drug class where you do not separate by ejection fraction. Yeah? Just start when the diagnosis of heart failure is there. The echo needs to be done, but you have time to do it. In some countries, including my country, it might take days or weeks even to get an echo. But postponing the treatments for in some countries it's months, and then postponing the treatment would be a very bad thing. What else can you do? You can look at the QRS duration, which is a marker of fibrosis, not only left-bundle branch block, that's clear, but also just small QRS durations. Here you can see the separation, and the higher, the longer the QRS, the higher is the outcome rate, and dapagliflozin has an effect throughout all. So you can take all risk markers, troponin, anti-proBNP, QRS duration. The treatment effect is homogeneously across all risk markers. Now, what is important? It could be like an inotropic therapy. You make the patients better. He feels better, he doesn't go to the hospital, an inotropic treatment. But then all of a sudden, all patients are better. Yeah? That is the difference between mortality and morbidity. Therefore, this analysis is important. This is delivered. You can do the same thing in DAPA. The first hospitalization is reduced, the second is reduced, and so on. Here you can see also urgent hospitalization visits and cardiovascular deaths, right? So over time, the subsequent reduction has a risk reduction of about 20% as well. So because the trials with the Kaplan-Meier is only showing you time to first event, you do not know what happens thereafter. But this analysis looked at all events, and this is the only way to do a proper cost-effective analysis. Now then, what do the guidelines decide? Dapagliflozin and empagliflozin are a class 1 recommendation in HFpEF and HFrEF. This is shown by Deliver and Emperor Preserve. They put both groups together, but had a pre-specified differential analysis of both of them without any difference. So therefore, you can see class 1 recommendation. These drugs only act through, let's say, 41 to 44. There is no dedicated trial. They work. Therefore, this 2B is not a bad classification, but it's not a very strong evidence grade because these are secondary analyses and meta-analyses by putting together trials. So this is here their effect, but there's a less strong recommendation as a defined dedicated trial in these patient groups. So we have new, and these were indeed the first class showing evidence in heart failure with preserved ejection fraction. Now people are concerned. Typical ask questions, my blood pressure is too low. You heard something about dehydration with SGLT2 before. My patient has a low body mass. There is a loss of 2 tins of Coca-Cola, so there is a slight reduction in weight. A loss of calories. Is it dangerous? Is the question. What about impaired kidney function, producing indeed the largest undertreatment and instability post-discharge? Now we looked at that here in the empagliflozin trials in heart failure with reduced ejection fraction. So we separated the whole group into those with really low blood pressure below 110, 230 and above 130. And what can you see? There is a similar analysis from the dapagliflozin, DAPA-HF trial. When the blood pressure is really low, there there is no further drop in blood pressure. However, over time, there is even a slight increase because the patients on the therapy that works become more stable. If the blood pressure is high, there is a 2 millimeter mercury drop in blood pressure. If you take diabetes with high blood pressure, then there is a 6 millimeters drop in blood pressure. The strongest predictor of the drop in blood pressure is the baseline blood pressure. The higher, the greater the drop. Now, what about the outcomes? We have a U-shaped relationship in heart failure concerning blood pressure at baseline. That means people with a low blood pressure, because there is a selection of sicker people, have a higher outcome rate. You can see it here. This is the incidence rate. Low at high blood pressure, high at low blood pressure. But you can see on every level of blood pressure, there is a significant reduction in outcomes, and you can see it here as a continuous variable. There is no statistical interaction with blood pressure and outcomes. So low blood pressure in particular, the effect is greater with subcutaneous valsartan, but the low blood pressure should not prevent from applying SGLT2 inhibitors. What about low baseline body mass index below 20, really slim patients, so that is a frequently asked question, and patients who are obese. What you can see here is that the higher the body mass index, the greater its weight reduction. It's about 500 grams in really slim people. So what you can see, the outcome is not affected by body mass. This is low body mass, also low body mass and higher body mass indices, heart failure, hospitalization, or the composite, no interaction. And with dapagliflozin, you can see the same thing. This is the outcome rate, primary outcome death, hospitalization. You can see that blue and red are completely superimposable. There is no interaction with body mass index, so no reason not to give it to these patients. Now, something was addressed in the pre-discussion, and this is the drop in eGFR. So this is a typical feature, change in kidney function over time. I brought you DELIVER because it's a newer trial. It looks exactly the same in the diabetes trial and in DAPA-HF, so the reduced ejection fraction trial. We have here a drop in blood pressure at average is about 3 milliliters per milligram. And that is, of course, the effect on the mechanism I spoke in the beginning about, and that is the drop in intraglomerular filtration pressure. Yeah? So there is this drop, and what you can see, that thereafter it is very flat. So the decline in kidney function is gone. And if you then go off, and then you go up with the eGFR back to baseline, I showed you this later, and then you have a maintained ejection fraction, and they stay down. So the mechanism of the drop is the same as the mechanism of the kidney protection. Here you can see the cardiovascular outcome. When you look here at the reduction, the treatment effect across of baseline ejection, baseline eGFR, low, has the same as high eGFR, so there is no interaction with kidney function. Now, what about blood pressure? You think of pressure diuresis. When the blood pressure is very low, below 110 down here, you can see there is still a protection of the kidney. That is pressure independent. Kidney protection is maintained. And when cardiologists hear something about sodium excretion of acute kidney injury, which was addressed in this hydration argument here, you can see after initiation there is, this is famous SGLT2, here's hazard 1, there is a 30% reduction of acute kidney injury. So the initiation is not really bringing the patient at risk for acute kidney injury. In placebos, 3 have it. On empagliflozin, in this case, we have on all these trials, this meta-analysis, including DAPA-HF, it's 2.5. So it protects from acute kidney injury. Now, what is the problem in heart failure? This is, of course, that when patients are discharged from the hospital, they have a very poor outcome. About 30% die or go back into the hospital. The reason is that they do not have guideline-directed medications and a high dose of loop diuretics, right? So that is a problem here. We call that vulnerable phase. Now, what happens to a patient when he's coming into the hospital on an SGLT2 inhibitor? So these are the data from the Emperor trial who came to the hospital, and then the doctors were mandated to keep the patients on the drugs. So on empagliflozin and on placebo, you can see that the in-hospital course of the patient is markedly improved. There was a 36% less reduction. I missed my point, excuse me. There is a 36% less reduction in IV vasodilator or inotropic fluids. You can make the same calculation when you look at days on the intensive care, which is also significantly reduced. Therefore, the patient decompensating on SGLT2 is in a better shape. So it doesn't move anymore. So this is an in-hospital cause, which is rarely investigated in these heart failure trials, which are focusing on chronic heart failure. So therefore, of course, it needs to be prospectively tested that the implementation in the hospital is safe. And there was one trial which was called the MPOTS trial, and these were patients who are decompensated in the hospital, and then in the hospital there was the start of empagliflozin. This facilitates in the long run the guideline-directed implementation because it is not forgotten outside the hospital. So what they did, they compared all the outcomes and compared every patient to every patient in approximately 600 patients, and you can see all the endpoints going to the right direction. And comparing all endpoints, there is a 36% higher likelihood not to die, not to go back into the hospital, or not to deteriorate with quality of life. So this is the MPOTS trial and the analysis we call win ratio. So therefore, this was taken up also in the guidelines that initiation should be done still in the hospital. Now, the most frequently asked question, what can I do with urinary tract infection patients? So 2 points, first of all. What we are talking about is not urinary tract infections. Urinary tract infections were not excessive in all the trials. This is genital infections, which is a difference, right? But of course, people are reluctant with urinary tract infections to initiate treatment. So first of all, this is here, the association of urinary tract infection with outcomes. You can see here, and this is the relative risk. No infection means 1 reference, and you can see cardiovascular death and heart failure hospitalization is 3-fold increase when somebody gets a urinary tract infection. MACE 2.8, renal outcomes 2.5, and you can go all over at cardiovascular mortality 2.6. That means the rest of urinary tract infection shows that this is a patient at particular high risk. Now, why is it so? Patients are discontinued from SGLT2 inhibitor. Here you can see the primary outcome, discontinued or maintained. And there is this huge effect of 30% over mortality. So urinary tract infection are patients who are older, sicker, and so on. So they need an exploration of it, maybe by transferring to the neurologist. But when you then discontinue uncritically without good reason SGLT2 inhibitors, you have a 30% increase of risk. So this should be avoided. Yeah? Sometimes you have to, and of course this increase of risk, it shows you in patients with diabetes and without diabetes, and then the subsequent patients here with diabetes, the incidence is higher, all have a risk more expressed on the heart and on the kidney. So do not withdraw it, and the withdrawal effect is very important. Also, when there is a genital infection and you withdraw it, there was an analysis from the EMPEROR studies that what happens after the stop of the treatment. So that was double blind. They were either on placebo or they were on SGLT2, and what you can see, nothing happens on placebo, but there is an increase in cardiovascular death and heart failure hospitalization. So this line is not here, it goes up. Maybe this is a withdrawal effect. So patients should stay on the drug. Withdrawal, even when they drop below 20 eGFR, might be dangerous. And here you can see also they lose the improvement of the KCCQ, the quality of life. So not stopping the drug is out a very good reason. Now what about CKM, chronic kidney disease? We have this new syndrome, and we have discussed already the association of diabetes, heart disease, and kidney disease. So inflammation might be the driving force for all of them. But in heart failure, kidney disease is the most prevalent comorbidity. You see it's slightly more pronounced in heart failure with reduced ejection fraction, simply because these people are a little bit older, so all the comorbidities are higher expressed. But what is the impact on CATT in heart failure? And I brought you this old slide, 20 years old, from the SHARP trial. You can see cardiovascular death and heart failure hospitalization with different eGFR. And compared from 90 to 45, we have a doubling of cardiovascular death and heart failure hospitalization. This is due to the impact of the kidney and also to poorer treatment, because many drugs are not tolerated, and then it is even worse because this is 45, below 30 were excluded in the SHARP trial. Now what is now the parameters we should look at? There is urine albumin excretion and eGFR. eGFR depicts a cliff where you have to go to dialysis. I got this from Christoph Waller, my nephrology friend in Würzburg. And the speed on how you approach the cliff is determined by urinary albumin excretion. Now, this is shown that indeed these kidney parameters and this speaks in favor of the chronic kidney syndrome increase new onset of coronary events and stroke and heart failure. On the left-hand side, you can see eGFR. The lower the eGFR becomes, the higher is the new onset of heart failure. And the more albumin you find in the urine, therefore you should look at it even as a cardiologist, the higher is the new incidence of heart failure. And what you can see, it does not start as an eGFR of 40, it starts at an eGFR below 16, and it starts not at microalbuminuria, it starts really once the urine is approaching, the albumin is approaching the urine. Very sensitive markers in the prediction of heart failure. Now what happens now in diabetes and non-diabetes, the kidney protection is exactly the same. These are data from Emperor preserved, and then it gets flat, so the drop indeed is there, but it is also a reflection of the protection. Now when you then look what you're doing when you go off the drug, you have an increase here in eGFR. This is a pharmacological effect, this is not chronic kidney disease. Now, therefore, we call that permissive AKA. This is a very interesting read from Kidney International, where they say there is an acute decline in eGFR. It occurs on ACE inhibitor, but also on SGLT2 inhibitor, but you should continue treatment. So we are now recommending don't even look at it. Don't even look at it. Because here you have the dippers on placebo. They are dipping without the drug. They have a problem in the kidney. Those who are dipping on DAPA, they have indeed the lowest risk. Yeah? With different words, here is 0, here are the dippers, here are the non-dippers. The treatment effect is accentuated when they are dipping. The reason is first, these patients who currently have taken the drug, who are dipping. And the second point is this might be reflecting a high neuroendocrine activation in the kidney. So these are the patients who really need it. You can see the risk goes up here, and then you have a strong treatment effect. So don't be confused by dipping. Dipping should not lead to the discontinuation of drug, because then you have more events and you have a loss of kidney protection. All of these data now from the heart failure trials, they were indeed crying for kidney trials. And the first study coming out was WFLOSI. The primary endpoint was doubling of creatinine, end-stage renal disease, and death from renal failure. And you can see that this was a very early separation of the curve. You can see also 39% risk reduction. This trial was stopped early because for ethical reasons there was no reason not to keep the patients on dapagliflozin. Not to keep them on placebo, but they should have dapagliflozin. And here you can see the specific renal endpoints. This is GFR drop and end-stage renal disease, and that's for renal disease. And you can see this undoubtedly best findings you can ever see in the trial. Now what happens here is that when you look at the same population with CKD, which had not heart failure in the beginning, they had also a significant reduction of deaths for cardiovascular causes and hospitalization for heart failure. So as in the early DECLARE trials and in the diabetes trials, this applies also for CKD patients who had a 29% drop in a typical heart failure outcome and a significant drop in deaths. That means CKD patients should be treated also to prevent heart failure. And this was then also seen in the empagliflozin trial, which is shown here. And here I brought you, this is the end of the observational period, long-term follow-up over 4 years. And what you can see, this effect is stable, right? Even though we do not know what happened here to these patients. It's published in the New England Journal. It's a long-term effect, long-term kidney prevention, and you can then prevent dialysis. Now, who were the patients included? Patients were included with two components. A normal eGFR does not mean no kidney disease. You can see it here. When an eGFR is 60 to 89, but there is elevated albuminurin, then they have indication for treatment because they have a higher risk. So in those patients, in particular, who have a rather maintained eGFR, one should take a look in the urine to detect urine albumin excretion. And then when you look at that, this is a meta-analysis of heart failure trials, and here you can see diabetes trials, all reduce heart failure and cardiovascular deaths. You can see here in kidney trials, they all reduced the outcome in heart failure. And therefore, this is important, and it is not affected by ACE inhibitors. Here is combination treatment of both and placebo treatment of ACE inhibitors plus SGLT2 inhibitors, and here you can see when a patient is approximately up to 55 years old, you save him 4 to 8 years of not going on dialysis or any cardiovascular endpoints. So this is good in the patient communication, very important, how much years of life you can save to the patients. Now, all of what I've said is now positioned in the guidelines. Prevention of heart failure is working in diabetes type 2. DECLARE, EMPEREC outcome, and also the CANVAS program. In CKD, DAPA-CKD have shown that, again, so CKD patients and diabetes patients should receive an SGLT2 inhibitor for the prevention of heart failure. That was the earliest recommendation we could get. We have here as a fourth line SGLT2 inhibitors as an independent class 1A recommendation in patients with reduced ejection fraction, and we have a class 1A recommendation in preserved and mildly reduced ejection fraction. That means independent of ejection fraction. They should be given for treatment and prevention of further deterioration. I think that is the right way. And if you do that, and you provide fast and strongly the 4 guideline therapies, you can see here the life saved, the difference in event-free survival between these treatment of beta-blockers ACE inhibitor or adding SGLT2 into ARNI. And again, in a patient up to 60, you save about 8 years event-free survival, meaning survival and not going to the hospital, and absolute survival on the left-hand side, overall survival, you save these patients 5 to 6 years. I think that is an excellent offer to the patient. So taken together, I hope I convinced you that we have this strong interaction between diabetes, kidney disease, and heart disease. We call that CKM, cardio-kidney metabolic syndrome nowadays. We have in CKD an increase in heart failure, an increase in diabetes, because it's an insulin metabolizing organ. We have in diabetes an increase in CKD and CHF, and in heart failure, accentuation of diabetes and CKD. And all of that we can prevent by SGLT2 inhibitors. Maybe there is phenomenon on the horizon. There are analyses ongoing. We have a reduction in CKD, in diabetes of these outcomes, in particular heart failure hospitalization. And in heart failure, it reduces the onset of diabetes and prevents also kidney damage. So therefore we have now a multi-organ intervention in all of these three conditions by SGLT2 inhibitors. With this, I would like to thank you for your attention.
Thank you very much, Professor Bohm. That was a very comprehensive and I must say interesting synthesis of the position of SGLT2 inhibitors in diabetes, heart failure, and kidney disease, the cardio-renal metabolic syndrome. I'll invite you to take your seat and invite the panelists also to take your seat. Yeah. So as they take their seats, I'd like to thank Micheal. They have been luminaries in educating us about the importance of SGLT inhibitors in different conditions. I think it was a year ago they invited Professor Mark Murray, who is also one of the principal investigators in many of his trials. At that time, it was online, but we are glad that this time around we could bring Professor Bohm physically to interact with us. Yeah. And the way we're going to do it, I know there are so many questions regarding the talk that has been given. And in summary, what Professor Bohm has taken us through was basically the risk of heart failure in diabetes and the risk of kidney disease in diabetes. He's gone ahead to tell us the position of SGLT inhibitors in the different subtypes of heart failure. Heart failure with preserved ejection fraction, heart failure with mid-range ejection fraction, and heart failure with reduced ejection fraction. And it looks like, dapagliflozin and empagliflozin, they work very well in that entire spectrum. Then he went ahead and educated us on when to start these molecules. And it looks like as soon as you notice that this patient has had failure, even within the hospital, you're better off starting the molecules. And then, of course, for the nephrologists and all of us, we positioned SGLT inhibitors in the management of kidney disease. And it looks like, again, just like heart failure, the earlier you start, the better for the patient. Now I'd like the Microlabs team to take the microphone around. We'll pick 5 questions from the audience. Before then, we'll move to our colleagues in Mauritius, who are also who have joined us and are going to be asking questions and also contributing to the topic of the day.
Okay, thank you so much. We are going to have the first 5 questions from here, and our team is going to be passing on the microphone. And I request that we do it very fast. The 5 questions, then our panelists are going to answer at once. So if you have a question ready, please raise your hand, and my team will be able to see you. Thank you so much.
Thank you. My name is Moses Tumba, resident in Dallas. I want to ask, if we have heart failure postpartum, and we're going to use SGLT2 inhibitors, lactation and the related effects, I would like to get some guidance on that.
Yeah, that is a very interesting question, a little bit difficult. because we have no trials in this specific form in heart failure. We know that bromocriptine, of course, to get rid of lactation, has a certain effect. And the guideline recommends standard therapy of heart failure. So we have then, of course, the standard therapy now is the 4 pillars. And also in the last guideline, this did not change. So independent of the cardiomyopathy, the 4 pillars should be there. And of course, also SGLT2 inhibitors. And in pericardial cardiomyopathy, we have a rather high rate of recovery, which is, of course, very important. So I would do in these young women everything to improve ejection fraction outcome. So it should be included. No, it cannot be a class 1A recommendation because there is no trial. It's a 1C recommendation that needs expert opinion.
All right, let's take 4 extra questions, and then we'll answer them at once.
I would like to ask, first of all, thank him for a very enlightening lecture. I would like to ask, it was not so quite clear how long the study has been going on. Can the speaker summarize for us, given the various impressive results of SGLT in the different components of the syndrome as presented? If you were to do Kaplan-Meier curves, where does the 50% survival occurs with SGLT involved as compared without them? I don't know what period the study overall has occurred for these compounds to be utilized. Can you summarize for us the impact of SGLT application in the treatment of these diseases, where the 50% survival is in terms of years?
That is a very interesting question which really cannot really be answered. That is the trials we are doing are always on top of standard therapy. So what we cannot say whether one drug is superior to the other because there are no head-to-head comparisons. What we can say that there is a 26% reduction approximately with the SGLT2 inhibitors on top of every therapy. We can say that there is a 20% reduction in HFpEF. First one was HFpEF. And this is really a difficult question how big is the treatment effect of a single drug? We cannot say that. When you take, for instance, the beta blockers, which primarily act via heart rate reduction, then the effect is very tiny. So data from CPS2, when the heart rate baseline is already low, 60. The biggest effect is achieved when the heart rate is above 80, and the effect is great. So in one trial, in a group of heart failure patients, there are several predictors of outcome, and the drugs affect them differently. Right? In SGLT2, you see absolute risk reduction is different when you have diabetes or not diabetes. With diabetes, it is higher. So a general rule, how much is 50% risk reduction by SGLT2 cannot be said. You can just say there is no interaction with baseline treatment, but it is done as a whole on top of all baseline treatments. I hope this was sufficient.
Okay, we'll take 3 other questions.
Yes, there is a question there.
Thank you so much for visiting and the education. And the research, that's what you are doing. But it was not clear to me with the studies concerning the pagliflozin, which strength were used, either 5 or 10, because here we have got 10 and 5 on market. So I don't know when should I give 5, when should I give 10 milligrams of pagliflozin, because I'm using it. Thank you.
So when I came into Africa, I was surprised that you have 5 milligrams. So the empiric outcome, for instance, the dose of DAPA and EMPA is the same. And we have only 10 milligrams for heart failure and for kidney protection, because the empiric outcome trial has shown protection is 10 and 25% in similar amount. So the recommendation in heart failure is always 10 milligrams. Also for DAPA, it's done with 10 milligrams study. So we do not know whether there is a dose-response relationship, which steepness whatsoever. We have no data on 5 milligrams, right? We give sometimes EMPA-25 in diabetics with a high glucose, obese people, high body mass index to get rid of more glucose, right? But the standard dose for outcome reduction is 10 milligrams. I do not know anything about 5 milligrams.
Yeah. And you're right when you look at the trials. Empagliflozin is 10 milligrams and dapagliflozin is 10 milligrams. Maybe Professor Okello, in your practice, when do you use 5 of empagliflozin or dapagliflozin, and when do you use 12.5 of empagliflozin? Because we do have those.
Yeah, so for dapagliflozin, I personally use 10 milligrams because that's what was used in the trials. In empagliflozin, maybe diabetic heart failure, because you're hoping that you'll get to the A1C quicker, but you also know that the trial really showed that 10 milligrams worked very well. I wanted my neighbor to comment on the 5 and 10 diabetes.
I think the takes more of an expert opinion. When it comes to the side effects of the drug, basically more of an expert opinion. That people say the incidence of pneumonia is too high. There are people who come and complain that I'm losing too much weight, maybe, but we don't have evidence to really suggest that 5 milligrams is effective. Maybe microlabs should explain why they got the 5. But as regards to what we read about, what the evidence we have is more 10 that has been studied.
So honestly, there is also no, this is a psychological phenomenon. People like to use low doses, and that is a catastrophe in heart failure. All heart failure doses are all treatments are underdosed, right? Only 10% at optimum, for an optimist, can reach the dose. And honestly, I've never used it. I've never seen such a problem.
Yeah, so Professor Bohm here talks about a very critical aspect in the management of heart failure, and that is dose escalation as the patient improves. In fact, when we get heart failure patients and they are hypotensive,
Oh, Gilbert, your eye.
very tiny doses of ARN, androgen receptor glycine inhibitors. And now we have the 5 milligrams of dapagliflozin and even lower milligrams of EMPA. So then the argument should be that as soon as your patient starts to improve, you should actually increase the doses. This is the disease where you increase the doses as the patient improves rather than reduce the doses. So that's important.
Yeah, I just wanted to add that the strong HF study showed this, that once patients were admitted with acute heart failure and placed on medical therapy, once their NT-proBNP dropped or reached 1,500, they escalated. Those patients did better than the ones who remained on lower therapy. So it's really, really important for all of us with depression and heart failure to escalate the doses.
Okay, good. We have 2 questions, and then we shall move over to Mauritius.
Yes, we shall have this question and the other one on the other table. Only 2, but we shall have the last set remaining for 5, so kindly prepare those questions with you.
Okay, good evening everyone. Thank you very much for the presentation. I'm called Maria. I'm a physician, though more biased in pulmonology. So my question is there any benefit of SGLT2s in right-sided heart failure? Because we tend to see more of those patients. And another one which is more cardiology-based, any benefits on for patients who have valvular heart disease? Thank you.
Which are disease again?
Valvular.
Valvular.
Yes.
So this is most interesting question. So you outed yourself as being a pulmonologist. So the primary problem of the right ventricle is then, of course, the problem of the lung. And there is no data with dapagliflozin, because also when the lung problem is not 100% resolved, and then it is very unlikely that a drug focusing on whatsoever, the heart, the metabolism, the kidney, whether this affects indeed the right ventricular function in pulmonary disease. There are small studies. You can extend this question also to complex valvular disease in adolescents and in children and in people operated. There are no data because these cases are so rare, and the hemodynamic in every case is slightly different. I cannot say much about it. There is one small study in the European Journal of Heart Failure which showed neutral results. But I would not eliminate that out of our thinking, right? Because there might be among this big family of different conditions, there might be somebody who is responding. It will be safe. And if you have the other indications like CKD or diabetes, I would go for it. Yeah? It is a little bit not, I know the answer is not satisfying, but that is my point. Valvular heart disease is similar. When you have somebody with MI, aortic stenosis, you fix the valve problem as good as you can. You can do it in heart failure with big hearts, mitral failure. All these micro studies have surprisingly excellent results. And then there is one study, and that is something which I did not mention, that is the DAPA-HF study, the DAPA aortic study. Patients after an TAVI, trans-arterial valve implantation for aortic stenosis, they got dapagliflozin and they have a tremendous benefit. This paper was published last year in the New England Journal. And the question is why? Because what they had is FF, kidney disease, and one of diabetes. So it was a no-brainer that there is a beneficial effect. And the reason why the New England paper took the paper as an educational reasons. Interventional cardiologists always think the problem is solved when they fix the mechanical problem. That's not the case. We've seen so many patients going out of the hospital after a valve intervention or cardiac surgeons, they go out without any drugs. And this should really sharpens your view on the post-interventional treatment, because FF, kidney disease, diabetes, they are still there and they still need to be treated. That was the reason for the DAPA-TAVI trial. DAPA-TAVI was the name of the trial. It's very interesting. So that is the point which should be a take-home message.
So it's interesting. There's also the aspect of misdiagnosis of right-sided heart failure. Some of those, people they're diagnosed as right-sided heart failure have a touch of left-sided heart failure, and a lot of these people tremendously improve when they're given either SGLT2 inhibitors or GLP-1 agonists. I don't know if Dr. Mutakiro is in the room here. Was he invited?
Yes.
We have a patient who we thought was right-sided heart failure, but the gentleman was obese. He was there. Dr. Mutakiro, maybe just briefly talk about that patient.
Our patient was. Thank you so much. Our patient is a unique patient. Obviously, he had the baseline drugs were a number, so it's very difficult to attribute the benefits to one single medicine. But he was a moderately obese patient with a body mass index of about 45, it's about 130 kilograms. So he has had several attacks of right heart failure. I mean, he had growths, DVT, right heart failure, some form of pulmonary, ended up in ICU. So we've had to give lots antihypertensive drugs, drugs for hyperlipidemia, and we, in a special way, of course, we had to give him a drug for weight loss, GLP. So we started him on this kind of Ozempic when it became available, and his weight dropped by about 10 to 12%, and this has given him very significant improvement. His right heart failure improved, his performance improved, especially he could tell us that yes, now I'm more energetic, I can do more things, I can perform beyond my expectation. So I wouldn't say yes, he has benefited from SGLT1 inhibitor. He has, to me, he has greatly improved from the GLT1 drug. And it's still early. It's about 8 months since we started the drug, but the benefits have been astronomical.
Yes,
thank you.
So that patient, I think, did not just have right-sided heart failure, because we thought that the right-sided heart failure was from chronic thromboembolic pulmonary hypertension because he's had multiple faults. But when he was started on GLP agonists, his markedly improved. And when we did measure the pulmonary pressures, they were obliterated. So I think that in your case, before you say the patient has just right-sided heart failure, it's important to make sure they don't have a contribution to left-sided heart failure, because those patients then will benefit from SGLT2 inhibitors and GLP-1 agonists. Maybe the last, if there is, or should we cross over to
Yes,
Mauritius?
we have one more, one last one, and then we cross over to Mauritius.
Thanks very much, moderator, thanks to the colleagues and the presenter. There are some patients who lose a lot of weight or hyperglycemia, and they want to stop actually, and we enter into that discussion over stopping, and your presentation, Professor, seems to suggest that stopping may not be very good for the patient. It may reverse the benefits. I don't know what insights you can give in that situation.
First of all, I have not seen a patient who lost a lot of weight. We have seen the data of weight loss across the baseline BMI levels. So usually the average weight loss in the trial was 1.2 kilograms, and then the weight is regained because you lose glucose, but people then take up more glucose, right? It produces a starvation metabolism, there's an increase in ketone bodies, which might be one of the mechanisms for the improvement of outcome, right? But losing much weight is very uncommon. If someone is losing much weight on SGLT2 and not on GLP-1 or the dual agonists, then maybe it requires a workup for cancer or something, or a secondary disease, because we know that the cancer incidence in heart failure is also increased. And it is even more increased when you put together heart failure plus diabetes, right? So I will do a workup on this weight loss first. It's very unusual that patients coming on losing weight so much. For the majority of patients, it is highly welcome to lose weight. It is not much. Yeah. And when they lose weight, the treatment effect is still there. And when they go off the drug, then you lose quality of life benefit and the benefit for the composite.
As we wait to join, are we ready?
Yes, we are ready.
Okay, so we are joining our colleagues from Mauritius, and the chair on that side is Dr. Mohammed Luto, who is a cardiologist at Sikia Hospital in Mauritius. So we'll have about 5 questions for you. for the panel here.
Yes, Dr. Okello.
I will give you just the talk. So we'll start with the first one. The first one is called SGT inhibitors is notable philanthropic effects beyond renal protection. Direct cardiovascular metabolic active reactions with that are completely independent from the glucose lowering and renal mechanism. And the question is, should we still use SGT inhibitors despite the EGFR is below 20 or below 20, just to have a benefit effect on the heart rate?
Dr. Luto, your question is not very clear. I think there's an interruption on your side. We didn't get your question pretty well.
Sorry. So the question is that SGLT2 inhibitors, they have benefit effects on the heart failure, this particular mechanism. And it is despite the effect of the glucose lowering mechanism. And the question is that should we still use SGLT inhibitors with EGFR which are below 20 will heart failure?
Professor Bohm, you seem to have gotten the question. Maybe.
So I've taken it in that way that you're asking when there are two situations, when the blood pressure and when the EGFR is dropping below 20 on treatment. I think that is one of the questions. Shall we discontinue? And the answer is no. There is the point is when you then go off the drug, then you lose the benefit of EGFR, and then you go even lower. And also, what is the indication or the exclusion criteria to treat is the EGFR at baseline, but not the follow-up EGFR. And we have just, it's confidential, but we are among us, I would say. There is a paper submitted now in those dropping below 20. And some of them are withdrawn and some of them are maintained. And those who are maintained are doing better. A very important paper, which is not out yet, but keep people on the drug. You ask also the mechanistic part. You say when the EGFR is going below 20, there is not enough glycosuria. So for kidney protection, we do not know whether glycosuria is necessary. It takes out, by inhibiting the transporter, oxidative stress out of the kidney, and thereby, of course, might have still kidney benefits. If you go off, then you have more oxidative stress. That is the reason why there is an increase also in erythropoietin, with an increase in hemoglobin, and that is all lost then. And the main mechanism of treating, in the heart failure mechanism, is maybe the increase in hemoglobin. Getting rid of it, there might also be a disadvantage in the heart failure outcome. So you better leave it. The other question is, what on dialysis? Nobody knows. There is a small British trial looking at that in dialysis patients. And in my view, it will be important to see whether there is a difference between those who have still a diuresis and those who are anuric. Maybe that is the difference. But here we do not have data. So if somebody is dropping below and has still diuresis, keep the patient on the drug.
So maybe before you continue, Dr. Luto, Professor Kalyesubula here, why don't you start when you find that the EGFR is below 20, yet you continue for the reasons that Professor Bohm has given, when the EGFR starts drops below 20? Why don't you start?
It is because of the evidence available. We don't yet have evidence to do that. Even we kept going down. Initially, people of CKD 60 were excluded. Then they found the benefit in some studies. Then they kept going down. I think we would go lower, and I think the professor has told us some more evidence. But when you are using evidence-based medicine, the diabetic guidelines and the KDIGO actually stop at 20, and when someone is on it, you continue. But if you are just beginning, you don't begin below 20. That's the guideline. The KDIGO guidelines 2024, based on the evidence available. But more evidence keeps coming, and perhaps this information might change.
Okay. You could continue your questioning or your comments.
Yes, I have answered the question. The second question is SGLT2 inhibitors modify the overall energy metabolism and causes a shift towards ketoglycosylation. Would this have adverse effects on mobility differentials in the long term? And this cause eating disorders?
Did you hear that? Is there something about that? Again, you keep dropping, unfortunately.
Yes, I'm going to repeat it. So SGLT2 inhibitors modify overall energy metabolism because of the shift towards ketoglycosylation. Does this have any adverse effects on cognitive function or eating disorder? And it causes eating disorder in the long term.
So the question is around cognitive function, I guess. Maybe anyone on the panel could answer that. Prof, any studies around, cognition?
Yeah, there is. First of all, that is a very interesting question. So there is a hypothesis paper on the mechanism. So what is caused by SGLT2 due to continuous loss of glucose is starvation metabolism, which indeed increases the clearance of damaged proteins. It's not specifically investigated in the brain. But there is other evidence when you have mice, you let them starve, then of course they have a better cognition. That is an old paper, very highly published, I think, in Nature. There is another paper in Science, when you have monkeys, you just let them starve. They live 2 years longer, 20% longer, and they have less age-associated disease, including dementia. And now there is one small trial on cognitive decline, which is submitted in patients with heart failure, and the cognitive decline is attenuated over time. It does not say anything about dementia, but it could be that there is something behind it, so we are looking for more data. Right? It is not unreasonable to assume that it would make sense to follow on that. Be very careful.
So Prof seems to suggest that the mechanism of SGLT2 inhibitors partly is to cause starvation, right? And that starvation improves cognitive function. I think it's Eric Topol who has done a lot of studies on starvation and different outcomes. And it's clear that when you starve yourself, you improve in many aspects. So eating is not a good thing. You still have 3 questions, but that was an interesting one.
One of the other questions is, SGLT2 should be initiated quite early in the treatment. And can it be initiated rapidly or just in the cardiogenic phase? For the patient is in heart failure, is cardiogenic shock. Can we initiate SGLT2 inhibitors?
I think you've spoken about that, but maybe you could.
Yeah, there are 2 conditions. First of all, we should start as early as possible after recompensation. That is the EMPAS trial, which has shown that. And there are small trials, one with DAPA, one with EMPA, in acute decompensation. So what acute recompensation is all about, getting rid of congestion as fast as possible. This might also have an outcome effect the year thereafter, and also to have a complete decongestion. Right? Only 50% of the patients are decongested. Those who are discharged with residual edema have a doubling of death rate in the following year. So make them really dry. And there are 2 trials showing that the utilization, or that is a little bit sensitization towards the effects of loop diuretics in acute heart failure. One is EMPAS trial, EMPAS is one after, and 2 other trials, and therefore it is at least to be shown that this is safe, but it is very hard to make an outcome trial in acute decompensation. These data are lacking, but all the evidence points toward an effect of SGLT2. What you should not do, get rid of them when they are coming on an SGLT2 inhibitor, and there will be more and more patients coming decompensated even on an SGLT2 inhibitor. Keep it because it facilitates the effect of loop diuretics.
Okay. Again, I think you have like 1 or 2 questions. You still have some questions?
One last question. It's a last question. Is there a link between glucose blood levels and the occurrence of genital infections? In other words, if the blood glucose is high, is there a higher risk of genital infection?
Yeah, that is, I would not say urinary tract infection because there was no signal. A genital tract infection, the incidence was much higher in the diabetes trials and in the heart failure trials, where not only 50% diabetes were enrolled. So apparently it's just a local effect of glucose providing a good soil for fungal infections. That is the principle. Therefore, hygienic measures are important. The patient needs to know that, although in the communication it is sometimes difficult.
Okay. Thank you very much for joining us from Mauritius and asking those very important questions, Dr. Luto. Okay. Now we'll come back to our hall here and if we take another round of questions. But maybe Dr. Lumu, you can.
Yeah, just got the text message from a senior colleague. And the concern of this senior colleague is that he has observed that many of his patients, SGLT2 inhibitors, have crossed different vascular planes. Strokes, PE, and is attributing them to the use of SGLT2 inhibitors. And the reason is because of dehydration they cause, increase in the hematocrit, and then hypercoagulability. So, what's your comment on this? Do you have any science behind this? Is there any evidence?
No, the concerns, I wouldn't take them too serious. The first reason is that the hematocrit in patients, in particular when they're hyperhydrated, or when they're 50% are iron deficient, 30% have anemia, so the increase of hematocrit is a good thing and not a bad thing. It might be also mechanistically related to the outcome improvement. There was one in the Canvas trial, there was one limited increase of the worsening of peripheral artery disease with a very tiny, at a very low prevalence increase of amputation rates. This was concerns in the very beginning, and this has never been reproduced. It might have been a by chance finding in the Canvas program, right? So that is not really a concern. And also, SGLT2, and I think that we can discuss it, is not a diuretic. There is an increase of water and sodium exclusion. It provides a negative sodium balance, but it's not typical for a diuretic because it goes very slowly, and there is many studies looking into it. It removes interstitial edema, and it does not so much deplete intravascular volumes in the acute phase, and that is indeed the problem. Patients with low blood pressure are intravascularly depleted but still have edema. You see that every day on the intensive care unit. And with SGLT2 inhibitor, which is very slow action, with very softly pulling out the sodium, you reduce interstitial edema. And that, by the way, is also good if it occurs in the capsule of the kidney and in the interstitial of the kidney decompresses the tubuli and the vessels. So therefore, this will contribute also to the kidney protective effect and to the improvement of kidney function. So the concerns are physiologically well taken, but there are no evidence that they are really practically relevant.
Okay, so issues around expert opinion should be well taken, but also taken to the scientific process. And it looks like from a lot of the studies that have been done, the impact of SGLT2 inhibitors on stroke were either neutral or there was a signal towards protection. Yeah, so I think that should be looked at, but also, maybe, if something like that was discovered, then maybe we need more trials around there. But I think the signal is that it's either neutral or even protective, maybe because of all the other effects that it has. Yeah. We will take just two other questions. because of time, and after that we'll close this session. I think there's...
Yes, while the team is standing, those are the only questions that we are taking because of the interest of time.
Yeah. Make them short because between you and dinner are your questions.
Let's start with the one behind.
Good evening, ladies and gentlemen. My question was how the risk of glycemic decay is prevented in the use of SGLT2.
Euglycemic decay, euglycemic diabetic ketoacidosis. So let's take this question as well.
Thank you very much. Mine is a bit of tapping into the nephrology aspect. Evidence shows that there's definite benefit despite the fact of a decline in EGFR after initiating GDMT. I'm wondering if, despite the fact that you're keeping an eye on the creatinine throughout this entire initiation period, sometimes it may take months while it is dwindling in the higher ranges. So from Professor Kalyesubula, I would like to find out, at what point are you comfortable allowing this creatinine to remain at certain levels significantly above the normal range while watching and waiting for benefit for GDMT in heart failure, particularly in the nephrology aspect?
So the first question first. So the euglycemic ketoacidosis occurs in fasting. So we address the 6-day rules, and I think that is very important. If somebody undergoes a bypass operation or even is in cardiogenic shock, you better stop it because of course there is no uptake. The risk is increased in patients on insulin, and of course there is one of the reasons why it should not be given in patients with type 1 diabetes. So that is my take.
Okay. Professor Kalyesubula, your take on...
I think from what Professor presented, I don't get your question. In a person who has a TFR less than 20, or the normal person who has heart failure, you have to break the question down. Because that drop, as they told you, has no effect on the TFR. The kidney function continues to be okay, and actually continues to pick up. So it should not worry.
Okay. It's a situation where the baseline EGFR is not known, and in the setting of acute heart failure with reduced ejection fraction, you have a rising creatinine, and the GDMT started. Quite a few of them can actually impact the changes in the creatinine. Now, from the nephrology point of view, when you're observing this patient, at what point do you then consider withdrawal of some of the agents because of the impact of the drugs themselves?
No, Doctor, I get this question. So, when we start especially in diuresis, there's a little drop in, GFR, but that shouldn't be the reason why it's called therapy at all, because it's partly part of the improvement. It gets worse before it gets better. But these are the questions that you see on a daily, that you and I see on a daily. And I usually call in Professor Kalyesubula to see those questions. But maybe you can comment.
I think we are not getting this.
The question is, you have patients who are heart failure.
Yes.
You have started to do all those medications. They are these and other things. Yeah. And then you have, early increments in creatinine,
exactly.
worsening, GFR. When do you start, when are you worried? When are you worried? Is that your question?
Yeah, it's a difficult question because usually when you start people on whatever drug that is going to cause a drop in blood pressure or a drug that is going to cause a drop in the effective arterial blood volume, the creatinine is definitely going to go higher just by issue even of concentrations. So that should not worry you because the patient is actually going to recover. But maybe what you are talking about is the issue of worsening the effective circulatory volume to the point that you are now making the kidney worse. That will probably depend in other patients beyond the heart failure. As you've heard Professor Bohm speak, is that you need to make the heart failure patients as dry as possible. Because if you don't, they will actually come back, be readmitted and everything. But in the context of the patient whom we usually treat, these patients have sepsis, these patients have low blood pressure. So in such instances, you have to look at the mean arterial pressure. Once the mean arterial pressure begins to go below 60, then you have to look at which drugs you are going to be taking off. But that's a different patient we are talking about. This is not a patient who just has the heart failure.
Okay, maybe Prof. Bohm, that's a question and your closing remarks.
So just when you have then when you have a drop which is inappropriate EGFR drop, when it comes close to acute kidney injury, and then you have introduced subcutaneous valsartan, probably an ACE inhibitor and SGLT2 inhibitor, you inhibit the autoregulation of the kidney concerning blood flow. And then you should definitely look at renal artery stenosis. Yeah. The workup, I think, is the most important thing, that you do not miss something, or you ask the nephrologist if there is inadequate microalbuminuria, proteinuria, that you have renal chronic lung disease, which is maybe beyond the horizon of the cardiologist, right? So these are others. But the drug effect, usually, if there is a 10% drop in EGFR, neglected. And the majority of patients, you do not have to take all the drugs in because they have a history of hypertension, and they are coming usually with an ACE inhibitor that they already.
Yeah, maybe Professor Okello, your comment on that same topic and general wrap up of this session, especially as regards heart failure, but also the metabolic concept.
I think Professor Bohm has given us a very, very exciting synthesis of the data that is out there. I think for most it was a good reminder of the addition and the value that SGLT2 inhibitors bring to our treatment of what is called cardio-renal metabolic syndrome. We have to, I think one of the things I've taken from this presentation is that we have to help our patients get on SGLT2 inhibitors and help them stay on this medication. The dangers are few and we have to monitor them. He mentioned, that graphic he used about tracking kidney function before you tip and go into the dialysis zone. So in addition to looking at the EGFR, we have to look at the urinary albumin ratio. I think partly that's what you're asking, to just see and train your patient and see how they're doing with this. But the benefits, as we've seen across the spectrum, has been excellent. And I wanted to ask Professor Bohm if he's got time, whether he has a preference between dapagliflozin and dapagliflozin, especially for heart failure with preserved ejection fraction. Otherwise, excellent stuff.
So there is no preference. We have done, there are meta-analyses looking also at the heterogeneity of the treatment effect in kidney disease, in heart failure, in particular in heart failure, and they showed in FREF, FMREF, and FF no heterogeneity, right? Sometimes you hear there was a slight significant effect, and here we missed a little bit of significance. This is mainly due to the risk profiles of the patients included in the trial. This is a class effect. The affinity to the SGLT2 inhibitor pharmacologically is rather similar, so there is no striking difference between the drugs for all conditions.
I've never seen a class of drugs that has striking effect size on different, disease processes like SGLT inhibitors. They are all within, on heart failure, 30% reduction. On kidneys, they mirror each other so much that you can change one for the other without a problem. Yeah. So thank you so much. First of all, to the audience, you've been such a good audience. Panelists, you added a lot of value on what Professor Bohm has given. And we'd like to thank Professor Bohm again for reminding us about the role of SGLT inhibitors in a whole range of conditions that are related to the cardiometabolic renal syndrome. But most importantly, to the people who bring us all this value microlabs. There have been luminaries in collaborating with us, but also schooling with us. I talked about their sponsoring. I think it was last year when they brought us Professor Mark Murray, who has worked with Professor Bohm in most of his studies. And again, he was talking about the role of these agents in cardiometabolic renal syndrome. The Uganda Association, again very heavily supported by Microlabs, will be holding its annual conference at Manyonyo on the 20th to 21st. And for a very select group of people who register early, you're going to get a 50% discount on the conference fees. So, if you haven't registered, please register. We are going to have this Professor Kalyesubula here talking about a similar topic and many more talks. So please register and attend. And the students, I think, you come in even more subsidized at very low rates. So please register. Thank you very much. Siva, the big boss. I can't see everyone.
They are very around.
And everyone for having us this evening.
Thank you so much. Thank you so much for all the round of applause. Thank you so much for blessing us with your knowledge. I'm going to request that before you leave the podium, please help me to request. One is to help cut this cake. And I'm going to request Dr. Mtakura and Dr. Micheal to kindly join us on stage. And one representative from Microlabs, so that we are able to cut our cake. Mr. Isna, kindly represent the Microlabs team. Dr. Mtakura. Of course, Dr. Susan, kindly join us on stage for the cake cutting. Yeah, because the ladies are best known in cutting cakes, they're the best. Dr. Maria, Dr. Sharon, thank you so much for accepting to do this. We are going to use only 1 minute. We cut this cake and then we are going to have gifting for our panelists. Thank you so much. The lady should be in the middle. You bring light to the world, so if you're not available, then clearly she was speaking darkness here. No offense to the gentleman. The honorable Bohm, make sure that all my delegates are able to be seen. If we are ready, please give me green light so that we can count down. Are we ready? So we are going to hand down on that thing, and we shall be spelling it. So we shall start with D, A, P, Z, I, N, W. Thank you so much. Thank you so much. Thank you so much. The panelists my panelists for 1 minute. My panelists kindly stay, and I'm going to invite our general manager, Mr. Mahesh, to kindly come and give our gift is going to our moderator for tonight, Dr. Clement. Give a round of applause. Thank you so much. Thank you so much, Dr. Kaima. Our next gift is going to Professor Kalyesubula. Kalyesubula, sorry. Thank you so much for adding value and to us tonight in the world of nephrology. Our next gift is going to Professor Lumu William. Thank you so much for granting us your time, as usual, for always having our backs. As my colleagues, we don't take it for granted. And our next gift is going to Professor Emmy Okello. Thank you so much. We appreciate it. Please, the round of applause is so little. Thank you so much. And finally, Professor Micheal Bohm. Thank you so much for gracing us with your presence. Professor, we thank you. And I know that there's been a lot of learning that has taken place today. Let's stand as he receives his gifts. Thank you so much. Thank you so much. Our panelists can now take your seats down there. We shall have what they can get down and then we'll take the picture. Thank you. We are going to have 1 minute, Ismail, 1 minute for you, and then we go on to the next. I know that people are hungry, but trust me, what we have prepared for you is going to compensate everything you forget about the hunger. Thank you. Ismail, 1 minute.
Thank you so much. I'm presenter Professor Bohm, the panelists, Professor Emmy, Professor Lumu, Professor Kalyesubula, and Professor Kaima for such a wonderful presentation. I'm sure everyone of us has benefited, and those online. Let's take a quick moment to look at the powerful brand Dabzin. That's doing more than traditionally expected glucose-lowering agents. This drug was launched in Uganda in 2023. So far counting 3 years, and we appreciate your support for the 3 years so far. There are a number of milestones that have been reached, a number of patients, Ugandan patients in different conditions, and I will not talk about the studies because they have been talked about so much in the main presentation. We have it in Dabzin 5, which has been talked about in a different way, but I'm sure every one of us has understood on when to use it. Dabzin 10, the ambient dose. We also have it in combination with metformin. With M and M+. M denoting 500 of metformin, extended release, and M+ denoting 1 gram of metformin. So we have it in 5M, 5M+, 10M, 10M+, a holistic basket for management of basically, I would say, NCDs. Type 2 diabetes, especially the combinations with metformin, and the plain that go for other indications that have been discussed. And I'll end with this video, a few minutes video. As a practicing doctor, have you ever had a patient who has reached a point of giving up on each and every management plan? I request you to listen or to watch this video, which is taken few minutes, very few minutes.
So we request that you say this video after during dinner. And Mr. Isna, thank you so much.
Thank you so much, and I'll have the request you to embrace dancing to many of your patients, and I'm sure they will benefit a lot. We were the first people to bring the Kalyesubula after the innovator at affordable costs. This brand is available in most of the countries and available, was approved by most of the stringent drug bodies like USFDA, UK MHRA, and of course our own NDA in Uganda. So we're bringing a high quality product at affordable costs to our population, and we humbly request you to embrace it to many of CKD patients, type 2 diabetes patients, heart failure patients, and so many patients who can benefit from this drug range. Thank you so much.
Thank you so much, Ismail. Ismail is the leader for Dobson. For those who do not know him, thank you so much. At this juncture, kindly allow me invite Mr. Mahesh to give his closing remarks.
Thank you, Ms. Janet. At Microlabs, we believe in partnership in practice, and today's event is a testimony that we practice what we preach. As Dr. Kaima has already mentioned, last year also, we had a similar event but online with Professor Mahmoud. Today we have with us Dr. Bohm, Professor Bohm, and next year also this series of events will continue. And we will continue being your preferred partner in your practice. So at the outset, I would like to sincerely thank each one of you for your valuable presence. And on all of your behalf, I sincerely thank Professor Micheal Bohm, who spared his valuable time and joined us here from Canada. Thank you, sir. I would also like to acknowledge immense contribution made by Professor James Kaima, Dr. Lumu William, Professor Emmy Okello, and Dr. Kalyesubula. As without them, today's event couldn't have been possible. I also take this opportunity to thank Dr. Krishna from Microlabs India medical team, Mr. Mahima from our East Africa marketing team, Mr. Sanjeev, our president, who encourages us to host such kind of events again and again. Thank you for all your valuable contributions, sir. Lastly, I would also like to thank Sheraton team and team, our technical assistant team. Without them, this event wouldn't have been possible. Lastly, I take this opportunity to thank my wonderful Microlabs Uganda team, without whom this event would have been possible. So thank you so much, guys. We shall meet again next time with similar kind of momentum. Thank you so much.
Thank you so much, our General Manager. Thank you so much for your closing remarks. Now, Dr. Kaima said that whatever was standing between us and dinner were the very many speeches and maybe the questions. So at this juncture, allow me, request my namesake, to give us a prayer before we have our dinner. You know the dinner is always filled with the Holy Spirit. Thank you so much.
Let's have ourselves and pray. Almighty and loving God, we thank you for the gift of life, and we thank you for the gift of the session you have had. We thank you for the knowledge that has been passed to us, for the care and the love of our patients. As we are going to have our dinner, may you go before us and may you sanctify for the glory of your name, the glory of His name, and trust in Jesus Christ our Lord.
Amen. Thank you so much. Please note, we have a performance right when our dinner is taking place. Please get your food and come back here. We have a main performance by Baraka Performers. And then there are also people who did not win separate, come back here. As you're having a dinner, all these things will be taking place. Thank you so much, and do have a great dinner ahead of you.